Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday edition. We know we have a lot of people coming back. Some people said this is their favorite show on Sunday night. It's my great opportunity and pleasure to welcome our speaker, Dr. Jeff Gerson. He's a graduate from Indiana University School of Optometry, and after which he did a VA residency, concentrating in low vision and ocular disease. He has been in several different practice settings, including a retina referral practice where he participated in several large clinical trials. Currently, Dr. Gerson is in private practice, which is a collaboration of both optometrists and ophthalmologists. He sees primary care patients. He has emphasis on retinal care and ocular disease. He enjoys having fourth-year optometry interns with him and the challenges that they present. He still does participate in clinical trials and uses many different diagnostic modalities. He's a frequent lecturer in the US and abroad and writes regularly for several optometric publications. When not at work, he enjoys traveling, working out, and spending time with his family. So with it, it's really my great privilege and pleasure to welcome Dr. Jeffry Gerson. Jeff, take it away, please.
All right. Thank you, Joe. Thank you, Greg. And thank you for everyone for spending part of your Sunday evening with us, with me. I'm flattered that you would do so. So the topic for the next hour and 40 minutes or so is diabetes. And so that's what we'll be talking about. As Joe said, I think that probably the most important part of an introduction of me is just that I'm in private practice. And the reason I think that that's important is that the practice I'm in is not a big referral center. We don't see tertiary care patients. I'm seeing patients coming in to get their eyes checked, just like what I assume most of the rest of you are. And as it turns out, in the average optometric practice, quite a few of our patients have diabetes, whether they know it or not. And so that's why this is such a relevant and important topic really for all of us to really be up on. So that's why I thought this was an important topic for us to be able to discuss tonight. Just for a standard disclosure, I've been on or am a consultant for a number of different industry companies. And I think what you'll find is really none of this has any effect on the content of the talk tonight. Is really none of these have any direct influence in any way on anything that we'll be discussing tonight. So hopefully you'll agree with that when we're done. So like Joe and Greg, I've been doing this for a while, maybe not quite as long, but been doing this for a while, doing lectures and getting to talk to colleagues. And one of the things that I've learned, especially when we're doing this virtually, is I know I've got everybody's attention right now, but I'm not sure if I'll have your attention in an hour and 35 or an hour and 40 minutes. So what I've started doing is beginning all my lectures with the conclusion. And I think that's important because if nothing else, I want you to get the important takeaway messages, because the way that I would gauge my success tonight is if when you go to your offices tomorrow or Tuesday or whatever day it is, that you do or say, or at least think about something differently because of something that we've discussed tonight. So that's my goal. And as I stated, I want to start with the conclusion. So my conclusion is that optometry really is on the front line of diabetes care, not just diabetic eye care, but on the front lines of caring for any patients with diabetes, whether it's through making an initial diagnosis of diabetes or diabetic retinopathy, or assisting in monitoring either one of those two. Again, whether it be diabetes or diabetic retinopathy. I think that optometry will likely take a more active role in diabetes care. And when I say that, I don't mean just in diabetes related eye care, in diabetes care, whether it be through treatment or education. And I really do think that all of you have the opportunity to make a difference in the lives of your patients that have diabetes and don't know it yet, or maybe they do know it and you're helping them through their journey of diabetes. I really think that as optometrists, we can and should be empowered to make a really big difference for these patients. So by the way, let me tell you about a couple of things I'm really not going to bore you with, because usually when you go to a lecture about diabetes, it starts with all these grand statistics to draw you in. And so instead of having a slide or two on each of these, I'll tell you that I'm not going to spend time telling you that there are about 30 million Americans with diabetes and over 90 million Americans with pre-diabetes, with up to a third of them not knowing about it. That's why this is such an important topic. the rates of increases in prevalence of diabetes, that there's more today than there was yesterday, and there'll be more tomorrow. We don't need to belabor that point. The fact that overall Americans and really people anywhere with diabetes have poor control of their disease, which leads to the complications that we all face with our patients. The overall cost of the economy, that diabetes is incredibly expensive, whether you talk about it as an expense to the overall healthcare economy, to your individual patients, to third-party payers. Diabetes is expensive. And I'm going to assume that all of you know the difference between type 1 and type 2 diabetes, that are absolutely different disease processes, very similar, yet completely different. So I'm taking for granted maybe that everybody's on kind of the same page and already knows at least these very basic facts. Now, what I do want to warn you about is this course is more about diabetes than it is diabetic eye disease. And when I talk about diabetic eye disease, I'll be primarily talking about diabetic retinopathy, although as we know, there are certainly other eye conditions that occur because of diabetes. So you might be asking, well, why am I going to talk more about diabetes than diabetic eye disease? Well, it's because diabetic eye disease doesn't happen without diabetes. In general, diabetic eye disease doesn't get worse unless diabetes is not controlled or taken care of. So I think it's really important that as a foundation that we learn about and are active in helping our patients care for their diabetes, not just their diabetic eye disease. So kind of an opening question or an opening thought that I wanted to just point out, because as much as we'd like to think that have the pandemic totally behind us, we don't. We're still in the pandemic. And I think that COVID is going to be with us for a while. And so what about eye exams for people with diabetes in the time of COVID? Should people be delaying their eye exams? And in some people, maybe it makes sense to delay some of their medical care in general. If people are very well controlled, have no issues, doing well, haven't had diabetes for a long time, then maybe delaying a little bit, although again, COVID's not going away, so I'm not sure how long they're going to delay it. But for some people, that may be an okay idea. But for many patients with diabetes, people with retinopathy that have had any progression, have poor glycemic control or diabetes for a long time, delaying their eye care could ultimately yield dramatically bad results. And one of the things that I've seen over the course of the last year is some of the worst cases of diabetic retinopathy that I've seen in my entire career. And they're mostly people coming in asymptomatic, but haven't been taking very good care of themselves and have been avoiding doctors and are just now coming in and they don't think anything's wrong and they have just unbelievably dramatic diabetic retinopathy. So that's why it's so important that our patients with diabetes continue with normal intervals of exam. So this is one of those patients. This is a 48-year-old with type 2 diabetes that she's had for about 10 years. Her A1C is 9. And that's one of the questions we always ask as part of the history. And when the tech is done with her history and comes out to get me, she says, "Hey, doc, I need you to be nice to this one. She's been shamed about her diabetes control and is very fragile, even started to cry. So can you just be nice to her?" And my response was, that's kind of implying that I'm usually not nice to people. Why do you think that you need to tell me to be nice? To which she says, "Well, I understand you're usually pretty nice, but this one's going to take a little bit of extra hand holding." And so she tells me the revision's 2020. She's got no complaints, but she's here because her doctor said she needed to be. And then I looked at her optomap images before I went in the exam room. And as you can see here, and I'll show you some closer up images, it's going to be hard to be gentle with this patient, right? Because usually be gentle means kind of sugarcoat things, tell them how good they're doing and have them back in a year or something like that. But it is not difficult to see this huge neovascular frond here, or all the neovascularization down here, or the neovascularization here, or the sclerotic blood vessels here. Now, this is in a red-free, which is something I highly recommend using, regardless of the type of imaging that you use. Using red-free will really make these pathologies stand out. Here's her other eye, arguably worse, with the same areas of neovascularization, preretinal hemorrhage. This is somebody that has high-risk proliferative diabetic retinopathy that needs to be seeing a retina specialist in the next couple of days to get treated. This is someone that was asymptomatic. So luckily, I was able to explain it to her and facilitate follow-up care for her without her crying. So I guess I was nice enough, but this is not really a gentle situation when someone presents with these signs. And I would contend that presenting with these signs is no longer a rarity, because this is someone that hadn't been seen for a while. And I think we're all seeing more and more of those patients. So a couple myths or facts. So, and whether these are for us or more so for our patients to dispel, everyone with diabetes needs insulin. Obviously, we know that that's not true, but oftentimes people with type 2 diabetes ultimately do need insulin. Diabetes only occurs in people that are overweight or obese. Absolutely not true. Oftentimes people that are lean or slender do develop diabetes. And as it turns out, the majority of people that are overweight or obese do not develop diabetes. And then type 2 diabetes is less serious than type 1 diabetes. It's kind of like, well, which type of diabetes is a better one to have? That's kind of like the AMD question, right? Well, which of macular degeneration, what's the good kind, the dry kind or the wet kind? And in both cases, the answer is neither. Neither one is good. Either one could end up being extremely, extremely serious and create big problems for our patients. So I think the other kind of key message that I would urge you to get through to your patients that I think we all know, but we take for granted, is that good vision on an eye chart does not equal healthy eyes. And that's so obvious to us, but some of the things that I state tonight will seem just so painfully obvious, but that's obvious to you, the medical provider, not so obvious to your patient, the layperson that's not a medical provider. It's also important that we help other medical providers to realize this, that just because your patient sees well doesn't mean that their eyes are healthy. And so I think this is a crucial, crucial point that we can't get across enough, that to our patients, to all members of the diabetes care team, about the importance of routine exams. So let me ask you some questions about diabetes in your practice. So this is virtual, I get it. So this is somewhat rhetorical, but if I was in front of you in person, I'd be asking you to raise your hand or to tell me or to, just speak out. But ask yourselves, who's seen a patient in the last week with diabetes? Now, if you didn't say yes, that just means you were at Vision Expo West for the week or somewhere else on vacation, because there's no way that you see a week's worth of patients and don't see a patient with diabetes. It's not possible. Who's seen diabetic retinopathy in the last month? So by the way, feel free at any time to put questions in the chat box. I'm monitoring that routinely. And the more interactive we can make this, I think the better it is for everybody. So at any point, if you want to put in a comment, a question, anything, I will pay attention to that. So if you saw 25 people over the course of the last month, then you probably saw someone with diabetic retinopathy, because you can do some number crunching based on some population-based studies to know that about 4% of Americans, that's not people with diabetes, 4% of Americans have diabetic retinopathy. So if you saw 25 people over the last month, you saw someone with diabetic retinopathy. So someone said, I served in the US Navy and went many weeks without seeing anyone with diabetes. That's an interesting point, because you're seeing young, healthy patients. What I would contend is you probably did go longer than most of us do without seeing someone with diabetes, but you probably saw people that had diabetes that didn't know that they have it. Somewhere between a third and a half of people with diabetes are undiagnosed. So hopefully you did go that long, but there are probably some people that just didn't know that they had it. Have you ever asked a patient if they want you to do more than just take care of their eyes? And that's kind of the crux of most of this lecture. And basically what I mean by that is, can I talk to you about, help educate you about things other than what's going on with your eyes? And that's something that I do on a very regular basis. So when you start asking your patients these questions, what are some of the things you might start to hear? I have borderline diabetes. I hope that none of you use that term in your clinical practices, because that's not a medical term. If you want to say pre-diabetes, that's fine, because that is a medical term. When someone says borderline diabetes, what that makes me think is they've gone to the wrong kind of border too many times. How about I used to have sugar, but now I don't? Well, I was just in Vegas, and apropos to that is that's like spinning a roulette wheel with your health, with your life. If someone says that, that means that maybe they think that their diabetes has gone away because now they take medicine. And that's just not the case. They may be measuring their blood sugar. It may be fairly normal readings, but they still have diabetes. It's the medicine that's helping control it. My diabetes is diet controlled. And my favorite with that one is just kind of look at the person. And sometimes I'm wondering, what kind of diet are you on? And you start talking to people about the foods they eat, and they'll say it's colorful. I meet all the food groups and I have an apple a couple times a week. That's not really diet controlled. So something else you'll hear is almost all your patients with type 2 diabetes are on the same 4 medicines. I'll give you the first one here. Let's see if anyone can type in the chat the other 3 that almost everybody on diabetes is taking. Anybody want to play along with me here? So the metformin is to control their blood sugar. What about the other ones? So someone's saying Actos, that's another potential diabetes medication. As it turns out, the other 3 I'm looking for are not diabetes related. Yep, so someone put lisinopril, exactly. And so the lisinopril is to protect their kidneys or their blood pressure if they have high blood pressure. So we're missing 2 more. A statin, exactly correct. There's a recent study that showed that people with diabetes on a statin have less incident diabetic retinopathy. What's one more thing that almost all your people with type 2 diabetes are on that is not a prescription? Anyone want to take a guess at that one?
And Jeff, I know you were having some spotty audio earlier, but the spotty audio comment is not on this end or your end. You're good.
Okay, perfect. Thank you. I saw that. Thank you. Aspirin. Yeah. So Alan, you're right. Aspirin is the other big one. And people are on an aspirin to prevent a heart attack or a stroke. So those are the 4 medications that almost all your patients with type 2 diabetes will be on. All right, so why do I bother with some of these facts? Because we assume that primary carers or endocrinologists are discussing all these things and giving out all the accurate information. You know what, when you assume something, you know what that means? So in the introduction, Joe mentioned that I enjoy having optometry students. And it's because I enjoy the teaching, but it's also because sometimes they're great fun. And so I had one optometry student not too long ago that was a little naive in life. And he came to me and he was telling me something and he said, well, I assume. And I said, well, you know what it means when you assume, don't you? He said, well, yeah, when you assume, it's like making a hypothesis. You're not exactly correct, but you think that might be the right answer. And I said, no, when you assume, that makes an ass of you and me. And he looked me right in the eye and said, well, why does it do that? I don't know, that joke usually goes over pretty well when it's in person. But anyways, we don't like to make assumptions. We shouldn't assume that our patients with diabetes are learning everything they need to know from their primary care doctors. Here's why. This was a study done about 4 years ago of about 150 primary care physicians that were affiliated with an academic medical practice. So academia, you'd think they'd know all the right things to say and do. Only 6% of them knew the lab markers for pre-diabetes, or the risk factors for who you screen for diabetes or pre-diabetes. Only 17% knew the lab parameters to diagnose pre-diabetes, and only 11% knew that if someone had pre-diabetes, they needed to change their overall behaviors and try to lose some weight. Those are incredibly low numbers. So let me quiz you. How many of these are risk factors for someone to have diabetes or pre-diabetes? Anyone want to take a guess? How many of these? 12. And if you said all 12, you'd be correct. And then how about this? What are the diagnostic criteria for diabetes and pre-diabetes? I'll show you that on the next slide. What's the minimum amount of physical activity per week for people with pre-diabetes? It's a really, really important one. Yeah, someone said all 12. Right, all 12 of them were. So physical activities, what we need is 150 minutes a week, 30 minutes 5 times a week to dramatically decrease the odds of converting from pre-diabetes to diabetes. So what are the lab markers for diabetes and pre-diabetes? Well, if we're doing fasting blood glucose, normal is under 100. Pre-diabetes is 100 to 125. 126 and above is diabetes. For A1C, below 5.7 is normal. Above 6.5 is diabetes. This is really important because just because someone tells you they don't have diabetes or tells you they've had blood work done, doesn't actually mean that they don't have diabetes. And when we start paying attention to these numbers, we really realize that. So What if somebody has an A1C of 7 and their doctor didn't tell them that they have diabetes? Does that mean they don't have diabetes? No, it just means they haven't been told. And I see that more frequently than I care to admit. That I'll see something suspicious in someone's eyes. I'll get their blood work that they've already had done, and they have diabetes. Now, in some cases, maybe they were told, but they just don't remember being told. But I think oftentimes they're not even being told. So, Greg, I think we're at a good point. Let's do one of our polling questions here.
All right, here we go. Which would you most want to visit? Yellowstone, Grand Canyon, Niagara Falls, and Statue of Liberty. When I was explaining to Jeff that they don't have to be questions that are like board certified questions, Jeff took it to this level.
Yeah, it doesn't have to be, you don't really need to think about it. You can make it fun. Why wouldn't you?
Exactly.
It's also because we had such a good time in Cody in that area that, man, that's why I listed that first, because boy, that was a pretty incredible place.
Yeah, it was. One of the lucky parts about being a lecturer, right? Never would have I ever thought to go to Cody, Wyoming. So
yeah, I'd say it's the best part.
all right, so we got a pretty good participation already. So we'll end the poll. Just so everyone knows, Dr. Salka did launch the handout into the chat. If you use that route of downloading it, I'll share the results while I'm doing that. Okay. And also remember, it was in the 645 email, and it will also be in the post-event emails. So there you go, Jeffrey.
All right, Yellowstone it is. Yeah, I have not been to Grand Canyon. I've been to the rest of these, and Yellowstone by far I think was the most awe-inspiring. All right, so when we're talking about blood tests, it's important that we kind of know what each one measures. Now, the standard test that people have when someone's looking for diabetes is a fasting blood glucose. So checking their fasting hyperglycemia. Postprandial hyperglycemia, you can measure that with an oral glucose tolerance test. Very frequently done in pregnant women, not very frequently done for anybody else. Because it takes more time and effort and therefore is more expensive. Is fasting blood glucose a great way to detect diabetes? As it turns out, the answer is no. Someone can have diabetes up to 5 to 9 years before you'll pick it up on fasting blood glucose, but you will pick it up on OGTT. Why do I bring this up? If you see a patient, you have findings where you're suspicious of diabetes, but their fasting blood glucose is normal, does that mean they don't have diabetes? It does not. It just means they do not yet have an impaired fasting blood glucose, but they may in fact have impaired oral glucose tolerance test, or they may have an abnormal A1C. So normal fasting does not necessarily mean no diabetes. So you can see what I'm already getting at is really the challenge for us as optometrists in diabetes care is thinking outside the box. Or really what this could or should say is thinking outside the eyeballs. Because if all we look at the eyeballs, then we can ensure that our patients are seeing well today. But unless we're looking outside the box and paying attention to their diabetes in general, we're not doing much to ensure they'll be seeing well tomorrow. So that's why I really think we need to think outside the box. We also need to kind of think outside the box with some of the words that we may choose to use with our patients. So for example, those who aren't what we call them, when you see a patient with diabetes, do you call them a diabetic? Many of us do. Now, you may or may not have noticed, I'm very careful not to do that. And so let me give you kind of an example to make my case. When you see somebody that has macular degeneration, do you call them a macular degenerate? And the answer is, of course not. That sounds silly. But if you call someone with diabetes a diabetic, that's the same thing as calling someone a macular degenerate. You're substituting some small part of them for their whole, for their entirety. So I think it's important just to pay attention to the words that we use. Don't substitute a part of a person for the whole person. I got this idea from my good friend Paul Chouse, and I love when he talks about this, but I think it's an important thing to pay attention to the words that you use. So now this is paying attention to the
Hey,
patients.
Jeff, I just want to echo on that,
Yeah.
so I've heard that before from patients from diabetes, don't call me a diabetic, I'm a patient with diabetes. They can reference that way. And on top of that, I really, when I do my lectures, like my thyroid lecture, there's 1 in 13 people with thyroid. So if you have 100 people in the audience, there's probably someone there, and there's probably someone tonight on this with 1 in 13 people that have, this condition, probably someone here tonight. So, the question is, what do you do? And what I found out, it's a patient with diabetes. So,
And
I agree.
Jeff, it is really a good lesson for us to consider, to remember. It's people with albinism too. That's a very important term.
Yeah. Yeah. You're right. Why don't patients? So a question that basically saying, why does this care fall on us as the optometrist? The way that I would answer that is a little bit different of a take. I would say that sometimes we have the opportunity to help do some of these things and help take care of our patients as their optometrist. I think if we look at it that way as an opportunity instead of a burden, then I think it allows us to do better by our patients. But it's an interesting question, why the PCPs or endos aren't covering all this with all of our patients, because they're just not. So let's say you go to the office tomorrow and you do a screening photography and you see this, you see just 2 small peripheral dot hemorrhages. What does that mean to you? And what I'll say it means to me is this person has diabetes and high blood pressure until I prove otherwise, because both those conditions are common and quick, cheap, and easy to prove otherwise. And now, if you ask me, is it normally a new diagnosis of diabetes? No, normally it's not. But it really is quick, cheap, and easy to rule those out, diabetes and high blood pressure. So don't just take subtle findings for granted. I think the only assumption we can make is there's something wrong until we can prove that there absolutely is not. Now, you might be saying, well, Jeff, that's just a couple, little hemorrhages out in the peripheral retina. Does that really matter? The answer is, yeah, they really do. That we know from studies that peripheral changes in the retina may actually be more significant than changes just in the posterior pole. That with changes predominantly in the peripheral retina, then that person over a 4-year period of time has 3 times the risk of their diabetic retinopathy getting worse, and almost 5 times the risk of developing proliferative disease over just a 4-year period of time, regardless of what's in the posterior pole. And if we don't look at the peripheral retina more than 10% of the time, we'll undergrade the level of retinopathy. We'll call it mild when it's moderate, or moderate when it's worse. And therefore, we won't have the right follow-up or referral schedule. So don't take those peripheral retinal changes for granted. Now, let's talk for just a second about treating diabetes as optometrists. And we know from different AOA estimates, and I think I have another number a little bit later, but hundreds of thousands of people every year are essentially diagnosed with diabetes because of findings by their optometrist. And so oftentimes we are on the front edge. And we're seeing, besides all these people with diabetes, we're seeing a shortage of primary care doctors and endocrinologists and people that need to be treating patients with diabetes. And I think it's not unrealistic to say that at some point in the future, that we as optometrists may have a bigger hand in caring or treating for people with diabetes, whether it's more ocularly or even systemically, or whether it's just using a lifestyle, or maybe it's oral medications. There's lots of ways we can really help our patients with diabetes. But it's kind of scary because around 40% of people with diabetes don't even think they need to have an eye exam. Now, maybe that's because they know they're seeing well, so they assume they don't need the eye exam, but that goes back to one of the earlier slides. Good vision does not equal healthy eyes. Most Americans don't know, this is of all Americans, don't know that you can have problems in your eyes, being diabetes related or even something else, without having symptoms. Really important point. And more than half Americans don't know that a comprehensive eye exam can actually detect diabetes, despite the fact that literally hundreds of thousands of times a year, it is an eye exam that is what diagnoses or finds diabetes. So this was from another year, nearly 250,000 identified by optometrists. And actually, it's likely that less than a third of all diabetic retinopathy cases are ever even diagnosed. The people just aren't seeing the eye doctor to know they have diabetic retinopathy, and sometimes to even know they have diabetes. So at this point, what I want to do is introduce two terms that I'll go into more detail later, but I think are really important terms for us as optometrists to, I think, even more than just be aware of, to be aware of and be ready and able to discuss with our patients. And those two terms are continuous glucose monitor and time in range. And I'll go into plenty more detail on both of these, but I want you to keep both those in mind: continuous glucose monitor and time in range. Now, all these things are obviously important in people that have diabetes. How do we know who's at risk for diabetes? Earlier, I listed that list of 12 different things, but I think, there's some of the simpler ones that we can all use when we go into exam room to know, who's more at risk. So who might we look a little more closely for diabetes or diabetic eye disease? So pre-diabetes, age, family history is a big one. So by the way, family history, for me, there's really only three things that I care about family history, medical-wise. And those three things are diabetes, glaucoma, and macular degeneration. Anything beyond that, I'm just not convinced that it has enough of a direct effect that it's worth getting into the weeds, getting all the details. What are the family history things that your patients are most eager or sometimes most frightened to tell you about? So I would tell you number one is cataract, which when a patient tells me they have a family history of cataracts, I tell them, congratulations, that means you have good genetics. That's a good thing. And then the other thing that people get real worried about a family history of, it's the stigmatisms, right? People tell you that, I think either I do or maybe one of my parents had the stigmatisms, because they don't realize what it is and they think that that's some really bad eye condition. So diabetes, glaucoma, and macular degeneration, I think, are the three main things that we worry about. And then if you're really worried about someone having diabetes, there's a really good diabetes risk test that you can get from the ADA, the American Diabetes Association. So diabetes.org/risk test. You ask a couple questions. It takes less than a minute. And with pretty good accuracy, it will help you to know whether somebody is at very high risk of having pre-diabetes or diabetes. Really, really simple. I did this for a couple months just to kind of pilot it in my office and see, and pretty accurate and super, super easy. And as it turns out, when you do stuff like this in your office, if some of us might say, I don't have an extra minute to add, or you might say, yeah, I could have a tech do that, or I could do that because I would tell you it doesn't take a minute. It's closer to 20 or 30 seconds. It was interesting to me, the different light it put on me for my patients. It created a much more medical perception, and it really kind of changed the tone of the exam just by asking these very, very simple questions. So I would encourage you to think about something like that, because what you'll find is people aren't very good at judging their own risk, because people that have a family history of type 2 diabetes assume, well, mom got that when she got older and got overweight, so I'm not really at risk of that. Well, if you have one parent with type 2 diabetes, you have a 50-50 chance. And if you have two parents with type 2 diabetes, you got an 80% chance. Whereas with type 1 diabetes, if both parents have it, you've only got a 20% chance. So this is, I think, another one of the takeaway messages is when someone tells you there's a family history of type 2 diabetes, to make sure that they know that they are in fact at risk. So Greg, let's do poll question number 2.
It's up and running. Can you see it on your end, Jeff?
I can see it. Yeah. So I really took it to heart when Greg said it doesn't have to be related to the topic. So I just put, what's your favorite color? Just kind of a random thing. Totally random thing. I guess what's your favorite color amongst the 4 choices?
There you go.
I didn't list fuchsia.
I was going to try and put the whole the color wheel on there for them so they can click, but I couldn't figure out how to do that. So
yeah, so we're stuck with the 4 choices.
You got something that popped in the chat while that's running.
Yeah, so it's someone saying they've been checking blood sugar levels for 28 years with the simple finger stick. If I feel it's indicated. When they ask, then we tell the patients it's a leading cause of blindness. This gets passed on to their friends and relatives. Yeah, So John, I appreciate you putting that comment in. I actually do that as well. And I think it's a fantastic thing to add into your practice. It's quick, cheap, and easy. And it really, patients, when they understand why you're doing it, it goes a long way, and it's medically indicated. The one thing that I'll point out, though, about doing blood sugar testing in your office is I am very careful to tell my patients, by me checking your blood sugar, it does not replace your routine labs. So blue seems to have won. My favorite color used to be, when I was a kid, it was yellow, and then it was red, but now I like blue. So I don't know why I put black in there. All right, very good. All right, so prediabetes. So what is prediabetes? So you can look at the numbers, you can look at the statistics, but prediabetes means if you don't do something, it is very likely you will develop diabetes. And there's about 90 million people with prediabetes. It means you're almost there, not in a good way, right? Normally we think, like, when we're looking at our watch an hour from now and we're saying, oh, we're almost there, that's a good thing. Being almost there in this case is not a good thing. So as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. So how do we prevent diabetes? Number one way is through healthy lifestyle, which, by the way, can you just tell a patient it's important to have a healthy lifestyle or change to a healthy lifestyle? No, because healthy lifestyle, what that means to me, what that means to you, what that means to your patients are going to be three dramatically different things. Generally, it means healthy eating, being physically active, getting enough sleep, not smoking, and being on the medications you need to be on if that's the case. But we know even more specifically what to do if someone has prediabetes and we want to help them prevent or delay onset of type 2 diabetes. So there was a study called the National Diabetes Prevention Program. And what it did was it looked at how do we, if we take people with prediabetes, how do we prevent them from developing diabetes in the diabetes prevention program? And there were three groups: either intensive lifestyle intervention, so lots of education, incorporating physical activity, changing diet, just taking metformin, or doing nothing. And this is basically what the results were. And that is that, and this is a different way to show it, but the way to explain it is the best way to prevent onset of diabetes if you have prediabetes is lifestyle intervention. And what it really boiled down to was 150 minutes of exercise a week, 30 minutes 5 times a week, and some diet modification, trying to eat healthier, less refined carbohydrates. That's twice as effective as metformin. Why is that important to point out? I'm going to make the assumption that none of you are actively prescribing metformin to your patients. Fine, no problem. Because if your patients have prediabetes, you can prescribe the best treatment: change in lifestyle. And so when I talk to people about this, I talk about trying to incorporate some physical activity. And I specifically say, that doesn't mean you need to start running marathons or pumping iron. It just means be active, go for walks, do something. So that's absolutely something we can do for our patients. And what we know looking 26 years later is the lifestyle intervention 26 years later, we know is still more effective than taking metformin. So yesterday, today, and I'm assuming into the future, the best treatment is lifestyle intervention, something we can talk to our patients about, or we can give them handouts or advise them to go speak to somebody else. But really, really important thing for us to know. So what does that generally mean, healthier lifestyle? Well, usually it means people losing some weight, and usually a 5 to 7% weight loss through healthy eating and exercise is enough to make a dramatic difference. People don't need to lose 20% of their weight or even 10%. Studies show that it's a fairly modest amount. That, stopping smoking if they currently smoke, and basically just taking care of themselves. Those are the things that really prevent diabetes. So why should we care about this? Well, we should care about this because every day people go blind from diabetes, and you won't go blind from diabetes if you don't develop diabetes. I understand some of the things that I say are painfully obvious, but for me, it's important to think of things that way. Come up with a very simple way to think of something for it to make sense and hit home and be something that I can then pass on to my patients. So I've mentioned healthy eating. What does that mean? So basically, and we've all heard about this before, the outside of a grocery store, right? So whole foods, non-starchy vegetables, lean protein, more fiber, trying to avoid saturated fat, not as much salt, and limit refined and added sugars. That's a big one. Eat food, not too much, and mostly plants. As opposed to the way that most of us eat. So the American diet is mostly comprised of food-like products, of which we eat far too much, of which most of it is refined carbohydrates with low nutrient density, lots of trans fats without any fiber. So that's what we are eating. And if we were to eat much simpler foods, we would all be much better. By the way, this is true for almost any eye disease or anything else. So I would imagine, Joe, you would tell me that if you had a glaucoma patient, they asked about diet, it'd probably be something fairly similar.
Yes, exactly.
So that's what I like about messages like this, is it's the same for everything, right? So when we're talking to our patients, we're not on some island telling them about something that sounds ridiculous. It's something they've already heard from Dr. Salka because of their glaucoma or their primary care doctor or any other doctor. It all makes sense. However, it's important to know that diabetes is not all about prohibitions. Chocolate is good for you. Chocolate helps reduce cardiovascular disease, carotid artery disease. So a little bit of chocolate goes a long way. Fast food, however, is bad for you. And about a third of young adults or children eat fast food on a daily basis. Crazy to me. All right, a little bit of exercise goes a long way. Again, I'm very careful to tell my patients, I specifically say, you don't need to run marathons or pump iron. All you need to do is be active, do something, go for walks. Going for a walk around the block or a couple times around the block does a lot of good. Now, if we do these things, does it eliminate the risk of severe eye disease? No, it doesn't. Some people will still develop eye disease or severe eye disease, but by doing these things, we reduce the risk. We can never make the risk go away completely unless we prevent diabetes completely, but we can certainly reduce it. So someone's comment is chocolate 72% or higher. So yeah, so basically when we're talking about chocolate, when it lists percent, that's how much of it is actually chocolate. And the rest, so if it's 72% chocolate, that means it's 28% sugar. So the higher the number, less sugar, the lower the number, more sugar. And yes, so it's not that, I guess, for a lower percentage, you need to eat more to get the healthy chocolate, but that also means you're eating a lot more sugar. So yeah, dark chocolate would generally be healthier, but there are studies that show that any chocolate, there's even been studies that show that hot chocolate are better than no chocolate at all. So exercise. So I've mentioned exercise as far as controlling diabetes and controlling blood sugar, but exercise is good for our general health, our cardiovascular health. It helps us lose weight. Really important, but underappreciated is how much exercise enhances our overall well-being. It helps our mental and emotional state, which is really important for diabetes because depression is more common in patients with diabetes and even more common yet in people with diabetic retinopathy. So as it turns out, both depression and anxiety are more common in people with diabetes. And not very often, but sometimes I do talk to my patients with diabetes about having someone to help with their emotional needs. And do you have a therapist? Do you have a psychiatrist? And because if you don't, I'm not the right person, but I'm at least someone that might be able to help you to understand that that person could be helpful for you. Because oftentimes people with diabetes and diabetic retinopathy have a fear of losing function and losing their ability to have a good quality of life, whether it be because of their eyes or something else. So again, mental health and diabetes, this is just pointing out that people with diabetes and diabetic retinopathy, especially as it gets worse, have more depression, even more depression, depression in all states of diabetic retinopathy, but oddly, lowest for people with proliferative disease. Maybe it's because they've had disease long enough and gone through enough treatment that they're kind of past that or have already sought assistance for it. But depression and anxiety in your patients with diabetes are real. All right, so we're about 45 minutes in. Now let's start to talk about the eyes. So why does diabetes matter for eye health? Well, again, the very obvious, but I like stating the obvious because these are the things we need to state to our patients so that we know that whether it's diabetes or prediabetes, our patients have a dramatically increased risk for eye disease. We know that about 20 and up in some studies up to 40% of people with newly diagnosed type 2 diabetes already have eye disease. Why is that important? Because that might be what helps you to diagnose their diabetes. Don't wait for someone to tell you they have diabetes for you to realize that they do. Diabetes is the leading cause of blindness in people less than 74 years of age. Interestingly, I saw a really well done commercial on TV yesterday about just disease state. It's talking about diabetic retinopathy. And it's by a drug company that makes a treatment for diabetic retinopathy and diabetic macular edema. It does not once mention their drug. It talks about people with diabetes. And if you have diabetes, you need to get an eye exam. And what's great about it is the people that administer the medication are ophthalmologists, but the commercial says that you need to get an eye exam. It doesn't say by an ophthalmologist. It doesn't say optometrist or ophthalmologist. So maybe it thinks people can just go to the DMV for an eye exam. But really it says by an eye doctor. So it's a really good commercial that hopefully will be driving some patients into our offices. Now, by the way, before we really talk about eye conditions, let me talk about a condition that could happen in your office with your patients, and that is hypoglycemia. So low blood sugar. If someone's blood sugar gets acutely high, is that going to cause them any acute problems? No. If somebody's blood sugar gets acutely low, could that cause problems? Yes. So it's really important as you get more involved in taking care of people with diabetes and paying attention to different things to be prepared for someone to become hypoglycemic. Have some sort of carbohydrate that they can take to quickly raise their blood sugar. So we have soda in the office, and we have apple juice, and we have glucose gel. By the way, if you have soda, it can't be diet. And again, I know that sounds silly and it sounds obvious, but in general, we think, well, if you have diabetes, you should probably be drinking diet soda. Well, two things. Number one, if you need to raise someone's blood sugar, diet soda doesn't do any good. Number two, interestingly, diet soda, studies show this, is just as bad, if not worse for you in many ways, including as related to diabetes and blood sugar. It's worse than regular soda. So have some regular soda, apple juice, and glucose gel in your office. All right. So eye care patients with diabetes need clear explanations and information, and not to just be made scared for the sake of just scaring somebody. We need them to know that just reading an eye chart doesn't mean you can see well, and that the only way to ensure you'll continue to see well is through routine eye care in an eye doctor's office. Diabetes and AMD are blood vessel issues. Strong nutritional support is critically important. Yeah, I couldn't agree with you more. There's a lot of similarities, and the messages between AMD and diabetes to our patients really can and should be about the same. All right, let's go back to the idea of what I told you to keep in mind: time and range and A1C. So this is just a slide to show you that whether someone lives in the US, Europe, or anywhere else in the world, in general, diabetes control is not that good as judged by A1C. And the reality is, even if we're using A1C, it's probably worse than what the A1C would indicate. What do I mean by that? Well, what we know from studies is that A1C is not the best predictor of who's at risk of developing diabetic retinopathy. It's something we've used and continue to use, but it is not the best predictor. Now, I say this, and we probably all feel that 10 years ago, none of our patients knew what A1C was. And now at least they're learning what A1C is. Unfortunately, what I'm going to tell you is we and our patients need to learn a new term. And the new term that they need to learn is because of the opportunity for our patients to use continuous glucose monitors. So continuous glucose monitoring systems, basically they render finger sticks irrelevant because they are constantly measuring blood sugar. So we know what it is at any time, all the time. And so I'll show you what they look like, but it's a way to be able to know much more accurately how your blood sugar is doing throughout the day at any time of day. So here's what a readout from a continuous glucose monitor looks like. It'll tell you on the top here what your average glucose was. It will then show you what percentage of the time you are in range. Time in range is between 70 and 180. How much of your day is in between those numbers? And then how much of your day is very high or very low? And what this one on the left also shows, that 6.3 is that's your simulated A1C. And on the right, again, it's just on the right, it's showing you what someone's goal should be. So the goal should be more than 70% time in range, very little time below range, so very little time below 70, and a relatively small amount of time above range. So being 180 up to 250 isn't terrible as long as it's less than a quarter of the time, but we certainly want to have as little time as possible above 250. So on the left, what someone's printout may actually look like. On the right, actual recommendations. So there's a great case to be made for switching away from A1C to time in range being the important metric. And then also taking into account how much of the time someone spends very high or very low, both of which can be dangerous. But, and they tell us about someone's glycemic variability way more than A1C. A1C is one number that gives us kind of an overall gestalt, whereas time in range gives us much more specificity. So here's one example of a continuous glucose monitor that is attached to somebody's abdomen, and then what their readouts look like, showing you either whether they're in range, trending up, or trending down. The most common continuous glucose monitor right now is a Freestyle Libre because it's the least expensive. What's interesting is that given if people start using a continuous glucose monitor, it has as much or more benefit to their A1C than starting a new medicine. So between 1 and 1.5 points on A1C improvement just by wearing a monitor, because you can easily see what your blood glucose is anytime, the trends, and do something about it. So they work incredibly well. So let me give you a very simple math problem to help explain why time and range is important. So if you look here, simple math, what's the average of 50 plus 250 plus 50 plus 250? You do that several times. It averages 150. And the average of 150 plus 150 plus 150 plus 150 is also 150. But do those two people have dramatically different outcomes? And the answer is yes. Someone that's stable, even if the average is a little higher, will do dramatically better than someone with big highs and big lows. And again, I'll go back to glaucoma and I'll ask Joe, I know that's where he's the expert. I would imagine it's the same with IOP, Joe, that if people's IOP has big ranges, but averages 18 or whatever the number is, they're not doing nearly as well as if they have steady measurements every day throughout the day.
Well, Jeff, there are some studies that support that, and others that actually don't support that. And we're kind of split in the glaucoma community. You know, is it the variability or is it the high peak that they're getting to? I don't think we really have an answer to that. But one would think that low, consistent, better. Variable, going high, not so good.
Yeah. Yeah. So I always try to come up with analogies to other things that we deal with. And I think that makes it easier to have basically the same explanation for our patients, but just with the different disease process that we're relating it to. This is just a study that's, excuse me, just kind of pointing out the same thing again, that time in range is what's important. It's more important independent of hemoglobin A1C. So A 10% decrease in time and range increases diabetic retinopathy risk by 64%. So as time and range goes down, that's bad. Diabetic retinopathy risk goes up dramatically. 10% time and range, 64% change in risk of diabetic retinopathy. Huge, huge numbers. Again, just more studies basically saying the same thing and really showing that time and range is important, not just for diabetic retinopathy, but for any health-related complication of diabetes. Plus, if somebody uses a continuous glucose monitor, they're able to see as they're going up or down, control it better, and as Joe just pointed out, prevent the peaks, whether it's with ultra-fast acting insulin, whether it's by changing the foods they eat, trying to do exercise or implement intermittent fasting, all these different things. You can use sensors to really help you know whether they are working. So what this is saying is that the goal is time and range above 70%. So time and range is kind of like bowling. You want a high score, not a low score like in golf. And that as time and range goes down, that's as this graph moves to the right, that risk of retinopathy progression goes dramatically up. So time and range, really important. So as someone's time and range goes down 10%, I already mentioned their diabetic retinopathy risk goes up 64%. Microalbuminuria goes up 40%. This doesn't just affect diabetic retinopathy. This affects diabetes and all complications. But the nice thing about this is when we're talking about diabetic retinopathy and when we're relaying this to our patients, hey, look, if we reverse engineer this, and this isn't exactly right, but if we reverse engineer this, we can say things like, look, by improving your time and range by 10%, you decrease your risk by approximately 60% of your retinopathy developing or getting worse. So, and again, more important than A1C, it's a new topic. And what I try to every year or two come up with a new thing to discuss with my patients. And so the last about year or so, my thing has been talking about time and range and continuous glucose monitor. So any of my patients with diabetes, hey, do you have a continuous glucose monitor? Do you know what it is? Great, you have one. What's your time and range? So, by the way, I want to tell you a little bit about my two best MD referral sources. The first one is a primary care physician that I'll tell you a little bit about later. The other one is an endocrinologist that I saw as a patient actually about a year ago. And when he was in, he was the last patient of the day. He came when he was done with clinic. It was my late day. He was the last patient of the day. While he was dilating, we just sat there and talked. And we were chatting, and I was asking him questions about time and range and percentages of his patients that use a continuous glucose monitor, CGM. And he kind of gave me a weird look. And he's like, how do you know about those things? And I was like, I don't know. I read. And he's like, but do you actually talk about those things with your patients? And I told him what I just told you. Yeah, all the time. Continuous glucose monitors are like my topic of the year this year. And I'm bringing it up so that patients know about it. And hopefully they're asking you about it. And he was blown away. He was just shocked that an optometrist would talk about these things with his patients. And the way that I know that he was impressed or liked it is he'd always been someone that referred a fair number of patients to our practice, but they were mostly going to the MDs that I work with. Guess what? Now they all go to me. And he sends his patients specifically to me because I talked to him about this. So that kind of helped me kind of feel even better and knowing I'm on the right track, discussing the right things. And it's what an endocrinologist feels is important. All right, so now let's talk a little bit about diabetic retinopathy. And actually, we've got a comment here. Let me see what it is. Yeah, so would you recommend the continuous glucose monitor to check for hypoglycemia on a patient with diabetes who's attempting a keto diet? And what's your opinion on a keto diet? So what I would tell you, John, is I think for anyone with diabetes, that a CGM gives great value. Now, the issue is that not all insurances pay for it. The Freestyle Libre, so that's the most common one, costs about $70 a month for the little monitors. they're replaced twice a month. So cost for some people is holds them back. But other than cost, I don't think there's a great reason not to encourage it. My opinion on a keto diet, if somebody asked me, which do you think is better, keto or paleo, or keto or Mediterranean? My answer is yes. And I know you're asking me for which is better. It's like our patients when we're doing a refraction, right? Which is better, one or two? And they say yes. And you don't really like that answer, do you? Well, same thing here. I think any diet where people are paying attention, and in diabetes, particularly paying attention to their carbohydrates, is a good idea. So one potential issue for people on a keto diet is too much protein for someone with diabetes can be harmful. It can be really hard on their kidneys. So one of the issues with different diets and kind of unique to diabetes is protein, and in particular animal protein. So that's where I think there's a little bit of hang up potentially with keto diet. My personal take is Mediterranean diet, because it's fairly forgiving. It's pretty wide in its breadth of what it allows. And studies show that it's very beneficial in diabetes, along with AMD and other things as well. Great question. Thank you. I appreciate it. So let's do our next polling question, because we're at I guess that makes for a good break point. So which of the following do you watch most on TV or stream of these different sports?
Jeff, I liked your comment about the chocolate, how chocolate is good.
In moderation, though, Joe.
Of course, in moderation. What a lot of people don't know is when you have nausea and vomiting, chocolate is the best food to eat.
Really? I did not know that.
Yeah, only because it tastes good going down and it also tastes good coming back up.
Mm. Oh, great.
And for that reason, one should also avoid spaghetti.
Along with chocolate, Joe, alcohol is actually also good for you. There's studies that show that alcohol helps with blood sugar control. It helps in studies, people generally have lower all-cause mortality with alcohol. But like chocolate, moderation is the key. So the studies with alcohol basically show that 1 drink a day, good, 2 drink a day, break even. More than that, you're losing ground. The really important one here, though, Joe, is if you haven't had any drinks for a couple of days, that doesn't mean you get 4 or 5 tonight. You still just get the 1 a day.
Mm-hmm.
All right. So basketball got the most, and my favorite, soccer, got the least. All right. And then one person said none, none of the above. Sorry. How much protein is harmful? That's a good question. I don't know the exact amount of how much protein is harmful if somebody has diabetes. It partially depends on kidney function as it is. So people that have very normal kidney function, then it's going to be a pretty high amount for it to be damaging or harmful. People that already have their kidneys compromised, the number is going to be considerably lower. So what's been the standard treatment for non-proliferative diabetic retinopathy? Historically, it's watchful waiting. It's you have this condition. There's nothing that we really can or are going to do. We'll see you more frequently. Let's hope it doesn't get worse. At least that's the answer that they'll get from a retina specialist, when really the right answer that we might give them would be, well, we can't necessarily improve it or make it better. However, through those lifestyle changes that we talked about earlier, diet and some physical activity and just healthier lifestyle, we think we can help slow down progression. So the answer is not always in the hands of a retina specialist or through the needle of an injection. So, but can we do better than watchful waiting for some of our patients? Well, we as optometrists in some cases can, through the lifestyle interventions that I've already mentioned. And by the way, just so you know, I mentioned earlier that, I'm in a private practice and see routine patients. And what I don't want you to think is I spend 20 minutes describing things and explaining things and educating patients. Just like you, I don't have the time to do that. I'll be at my office tomorrow afternoon from 1 to 6, and I'll see somewhere between 18 and 24 patients. And probably if I see 24 patients, probably 5 of them will have diabetes and will require some of this explanation. My whole thing is coming up with one-liners. Come up with a one-liner to describe whatever it is that you need to say. I'd like to for you to have a healthier diet, more green leafy vegetables, less refined carbohydrates. Need you to think about some more physical exercise, which means you don't need to run marathons or pump iron. Just do something. For me, almost everything needs to be boiled down into a one-liner. So someone's saying that if we eat a primarily plant-based diet, that improves many disease states. It absolutely does. The difficult part about that comment, though, is it is an extremely small minority of Americans that eat a plant-based diet, not even just plant exclusive. We're not talking vegan, but a primarily plant-based diet. And there was a study that showed that if someone with diabetes goes to a dietitian for advice on diet, then on average, the dietitian will get them to increase their fruit and vegetable intake by 1 serving a day, actually less than. So I'm not so naive to think that as an optometrist, I can get a patient to do better than that. I realize that less than 1 a day improvement is what we can expect. Doesn't mean we shouldn't bring it up, but that's why for me, distill it to a one-liner. If they need more, here's where you need to go for that.
Hey,
So,
Jeff. Hey,
yeah.
Jeff, as you know, it's Greg. And as you know, over the last about year and a half, maybe 2 years, I've really moved into trying to help the patients nutritionally, having that talk in the practice, maybe recommending supplements and so on and so forth. And in doing that and talking, trying to unravel this mystery, I've been speaking to a lot of nutritionists, and I heard a nutritionist say once, it's easier to change someone's religion than change their nutrition or diet. So I think it's true.
And that's a scary thing, isn't it? It's just because it's not easy to change someone's religion. It's just so hard to change their diet. That's a great point, Greg. That's a great point.
Yeah, probably they're not going to change their religion, but it brings it kind of to light what a nutritionist felt about that.
Yeah.
So.
Yeah. Geez, if we think we've got a hard job, they've got it really tough.
Yeah. How about it, huh?
So let me get to this comment here. We kill ourselves through our mouths. Yes, you're right. With the things that we eat and drink, we are our own worst enemies. So let me ask you: are you surprised to know that? I'll show you in a second. We think of diabetic retinopathy as mild, moderate, severe, or proliferative. Are you surprised to know that this is not the only diabetic retinopathy grading scale? That there's more than one scale used to grade diabetic retinopathy. So the one on the top here is the one that we are used to using. However, in clinical trials, they use either the second or the third scale here. Why? Well, because in clinical trials, the more information you have, the more likely you are to see signals or differences or find things that are significant. And so with diabetic retinopathy, the more stages you create, the easier it is to see if we can affect the stage or the progression or regression of diabetic retinopathy. So in the coming slides, when I talk about, you'll hear me say 2-step regression. That means getting 2 steps better on this middle or bottom scale. So not from moderate 2 steps to no diabetic retinopathy, on this middle one from level 47 to 35, or from on the bottom 5 to 3. You'll understand in just a second. Now, I want to preface it by saying that it's important to realize that diabetic retinopathy can quickly progress from any scale. It's no surprise that if someone has severe non-proliferative, that they're at high risk of developing proliferative disease over the course of the next year. But if people have only mild retinopathy, they have a 5% chance of progressing to proliferative in just 1 year. Think about that for a second. So if you have 20 patients in the next week, month, quarter, whatever it is, with mild non-proliferative diabetic retinopathy, you will likely have one at least that progresses to proliferative in just over a year. So don't take for granted that even those mild patients need to be monitored more closely. Now, we know the worse it is, the more likely you are to get worse, but even when it's not bad, it still has a reasonable likelihood of getting worse. This is also telling us the worse it is at diagnosis, the higher the likelihood it is to get worse in a fairly short period of time. This is over 4 years. And then as it does get worse, especially if someone develops proliferative disease, they're far more likely to develop, to have real vision loss. And that's really what our patients worry about, right? They don't care, well, what level do you call this? They want to know how's my vision and what's going to happen to my vision. So let me just show you what I was talking about before about the 2 steps. So let's say we start with the patient with what's called severe non-proliferative diabetic retinopathy that looks like the picture that we have on the screen here. So using the ETDRS, so that's diabetic retinopathy severity score of 53. We'll use that. Let's see what it looks like when someone has a 2-step improvement to level 43 to just moderate. And you can see there's less change on that photo. Let me go back one. You see what it looks like there. Same patient regresses, gets better to this. Have you ever had that? Have you ever had a patient whose diabetic retinopathy gets noticeably better from something that looked kind of ugly to now doesn't look good, but it doesn't look ugly? That's reality today. So there's been a number of studies with different anti-VEGF injections to show that we can get people's diabetic retinopathy to improve. And so I'm showing a couple slides that talk a little bit about a study called Panorama. This was using the medication Eylea. And this was taking people that had moderately severe or severe non-proliferative disease with no DME and then starting them on injections. So you might say, well, what's moderately severe? And for me, this is kind of the tipping point, and I'll share with you why that is in a minute. But moderately severe, let's say what's severe. Severe is someone that meets the 4-2-1 rule. So 4 quadrants of pretty noticeable hemorrhage or microaneurysms, or 2 areas of venous beading, or 1 of ERMA. So that's 4-2-1. And moderately severe is looking at someone and saying, boy, is that severe or not? I can't quite tell. It's certainly more than mild, but I can't quite tell if it's severe. That's moderately severe. And I think the best way to describe those patients is those are people that are on the edge of a cliff, that they're about to fall over. And what this Panorama study shows us is that if you start treating them before they fall off the cliff, before they develop proliferative disease or diabetic macular edema, that you pull them back and you prevent bad outcomes. What this study actually showed is if you take these people with this moderately severe retinopathy, you only need to treat 3 to prevent 1 vision-threatening complication, to prevent 1 person from developing proliferative disease or center-involved diabetic macular edema. That's actually a really, really good number for NNT, number needed to treat. Now, the percentage of people that have, excuse me, at least a 2-step regression in their retinopathy, well, if you're looking at people that start with moderately severe, they start getting treatments, it's somewhere around 60% will get at least 2 steps better. That's impressive. Now, by the way, that NNT, number needed to treat, of being only 3 to get 1 with a big benefit. Well, if you look at things that are standard all the time, like people being on a statin, so the number of people you need to prevent 1 cardiovascular death over 5 years, if they have known heart disease by taking a statin, is 83. The number to prevent a fatal MI is 39. And if someone has no history of heart disease, you have to treat well over 100. So only needing to treat 3 to get 1 to benefit is a really, really favorable number. So basically what this study said was that one thing they found actually was that retina specialists undergrade diabetic retinopathy. And the reason that's important is because when you're seeing a patient and you think it's moderate, there's a pretty good chance it's actually severe. One of the things that really shows us that we undergrade retinopathy is when people have a fluorescein angiogram. that fluorescein angiograms show retinopathy that you don't oftentimes see, or especially if it's proliferative, that you don't see when it's subtle on clinical exam. So yeah, so fluorescein angiography is really, really important. So anytime if you're in question and doubt of how bad the level of retinopathy is, I think a referral is in order, especially to have a fluorescein angiogram. And we found out in Panorama, but also in studies using Lucentis, that anti-VEGF therapy can essentially turn back the clock and reduce the risk of bad outcomes by reducing the severity of the retinopathy. So we've got a comment here. It seems like it's about blood vessel fragility or how porous they are. We need to guide patients to strengthen their blood vessel walls through better nutrition. I totally agree. You know, it's so true that nutrition is at the foundation of so much of what happens in healthcare. But as we pointed out earlier, it's easier to, as Greg pointed out, easier to get someone to change their religion than to change their diet. So it's really important. Doesn't mean it's not worth trying. It just means it doesn't happen very often. So by the way, what's the downside of these studies? The downside is these are people getting intravitreal injections. And in the studies, they got it once a month for 2 years. And that's not going to be very palatable to many of your patients that have great vision, because most of these people have great vision. So ideally, there would be a way to find, well, how do we get it to step back, then scale back on injections so that it's not ongoing treatment long term, because obviously diabetes is a long-term condition. All right, so protocol V. V stands for very good. These are people with diabetic macular edema with very good vision. So center involved DME, very good vision. So what's the best treatment for them? Laser, injection, or monitor for 2 years. As it turns out, there's no statistically significant difference between injection, laser, or monitor at 2 years. They all did the same. There was no difference in people losing letters of acuity. Really no difference in people being 20/20. They were the same. Now, I'm not saying if you have someone with macular edema, don't refer them. I'm saying if you're comfortable following them and you have an OCT and you want to follow, and as long as their vision remains really good, that may be reasonable. But that's not saying don't refer them. It's just saying they likely don't need treatment. And if you do refer them, it's not a urgent same-day referral. It's someone that if they get in a month or two, or maybe even longer, that may be fine. That may be fine for them. So this was really an interesting study. By the way, I think I'll get to it. Have you noticed that the term I'm using is diabetic macular edema, or center involved diabetic macular edema? Have you heard me say clinically significant macular edema? You haven't, and I'll get to that in just a minute. So there's another study, protocol S, that looked at using injections versus PRP for proliferative disease. And it showed the injections to be non-inferior, which doesn't mean they're as good, but statistically speaking, essentially means they're as good. Why do your patients not only get injections now instead of PRP? It's because injections only, oftentimes people get lost to follow-up, because injections, you need multiple over time. Whereas PRP may be a 1 or 2 and done. So that's why oftentimes people get some laser and then some injections after that. We're getting close to the end, so I want to do our next polling question, Greg. Let's go ahead and do that. So
It's up and running.
Yeah, something eye related. Which do you find to be the most fun when you're in clinical practice? Is it fitting spherical contacts, caring for retina disease patients, caring for glaucoma patients, or doing low vision exams? And it can't be none of the above. If you had to choose one, what would you say?
Jeff, you forgot to add contact lens insertion and removal training.
Oh, but yeah, that's a lot of fun, Joe. Who doesn't love that? But isn't that what YouTube is for? Isn't that how people learn these days?
Yeah. Hey,
That's
Jeff,
how
will you discuss, are you going to discuss, we have a new, a biosimilar in eye care. Will you be discussing
Yeah.
that?
So actually, I didn't have that put in, but it's called BioViz, BYOOVIS. It's the drug. That's the trade name. The actual drug molecule is ranibizumab Nuna. I don't know what Nuna means. But yeah, Greg, it's a biosimilar that was approved just this week. So basically saying that it's very similar, essentially the same, but it's not, as ranibizumab, as Lucentis. And it's approved for all the same indications as Lucentis. There was a study using it, comparing it to Lucentis with about 600 patients, where it performed very similarly. Although it was approved this last week, it will not be marketed until second quarter of next year.
And the reason why I want to bring this up, Jeff, is that there is a post-event survey, and I know that's one of the questions, so I wanted to make sure we covered it.
Okay. So something about, did I cover what's going to be on the post-event about the biosimilar?
Yeah, we just needed to make sure that that the audience is aware that there is one of the first biosimilars. Because some of these docs know that Dr. Offerdahl, who's a pharmacist, and I lecture together. We have a biologic and biosimilar lecture that we talk about. And I thought that was pretty neat. I learned that from you, and I thought that was going to be in your talk, so I made it one of the survey questions.
I apologize. Yeah.
Yeah, no worries.
As it turns out, it's the first biosimilar in ophthalmology, and I believe it's the 31st biosimilar approved by the FDA. Period. So
I'm gonna let you know what those 4 letters are at the end.
Yeah.
Nuna means nothing. Since they are biosimilar and you can't really get a generic, because you can't call them generics, that's why they call them biosimilars. All these things are going to get entered into a registry. So they all have to have the same name, right? I don't know, amumizumab, or all the different names that are out there. They got to be the same name. So those 4 letters are randomly picked. So when they go into a registry, they can be tracked to see what's happening. So it looks like someone leaned on the keyboard. So if you look at Tepezza, or I know this one because I talk about it all the time. Let's go to Oxervate, where it's Centergermin, and it's BKBJ at the end. The BKBJ means nothing. It's just so that when they come out with a biosimilar, it's going to be Centergermin something else, the 4 letters, to be able to tell when it gets into a registry.
Got it. That makes sense.
So it's not really Nuna. It's just I guess NUNA. So we can say Nuna, but
it's interesting because I actually tried searching. I mean, for what does Nuna mean? And I came up with a bunch of nothing. So I thank you for telling me. That saved me a bunch of time.
So there you go. So at the big, so the biosimilar, the biologics to come out now, like Tepezza, it has the 4 letters, but the original, what they call the reference molecule, does not have those letters. So you'll see them. So that's the difference. You don't have to look it up now.
Perfect. No, I appreciate that, because I had spent too much time already trying to look that up and didn't come up with that. So I should have just asked you.
There's your results for your, were they shared and taken down? Did you get?
I did.
Yeah, they were shared and took down. What was the answer, Joe? I didn't even see. What
there you go. I'll share them again.
Fitting spherical contact lenses.
Okay.
And as usual, low vision gets hammered again.
Yeah, that's what
quite unfairly.
But the reason I put that up there is because I expected that to be the answer. But it is so important to keep low vision in mind, even if you don't do it. And I understand that most people on here don't do it. But what I tell when I have a live audience at the end of a talk about AMD, or if I'm talking specifically about diabetic retinopathy, I'll ask in the audience, anyone that does low vision in the audience, raise your hand. And then they start to put it down. I say, no, keep your hand up. Keep it up till I'm done with this. Anybody else in the room, look around, find someone with their hand up so that you know where to send your patients. Because I'll bet you don't do cataract surgery, but I bet you send patients to go get it done. And just like you send patients for cataract surgery, you need to send patients for low vision. So Like
And
you
Jeff, I just want to clarify the people that are attending this Zoom meeting tonight, they are alive. So they're just not present. So.
well, I imply they weren't.
Well, you just said, well, do you have a live audience? It sounds like that these
Oh,
ones are a
I'm
dead audience.
sorry.
So
Sorry. An in-person audience.
there you go.
My
Just,
bad.
all right, just having some fun.
I know.
I'll quit stepping on you. Go ahead.
Some fun at my expense, which is always fantastic. Thank you. So as I already kind of mentioned, I've not said CSME except for to say I don't say CSME. And I did a talk with a retina specialist last week, and I asked him, I said, do you ever say CSME? And he says, no, never. I said, do any retina specialists currently use the term CSME? He said, really? No. And so the terms are that someone either had, and I'll say what the initials mean, CI or non-CI DME. DME stands for diabetic macular edema. CI stands for center involved. So center involved means if you do an OCT, you know that tiny little circle right in the middle? That's the center. If there's no diabetic macular edema there, then they don't have CI DME. If there is thickening outside the center, then that's non-CI DME. So those are the right terms to be using. Could injections become a thing of the past? On the top here, you see when you have an injection, a bunch goes in, it goes up, it goes down. A new injection, a bunch in the eye, then it quickly goes down. Wouldn't it be great if there was a way to get drug in the eye that just kind of slowly changes? So this is a quick video of someone getting what's called a port delivery system. So this is a retina specialist doing a quick procedure in an operating room. It really is a fairly quick procedure for people to have done. They're creating a small little opening. And then what you're going to see here in a second is they're going to take this little port and put it in. It's kind of like using a punctal dilator, then taking a punctal plug and putting it in. Kind of similar, not really. And then this little port is filled with medication and then gets refilled about once every 6 months. So one OR procedure and then refills about every 6 months. And what we see is visual acuity is statistically the same as someone getting injections every month. The difference is people only need a refill about once every 6 months. The medication in the actual port is the same as the drug ranibizumab, except for it's at 100 times concentration. So very highly concentrated drug elutes out very slowly over time, maintains its benefits. Do we have one more polling question to get to, or do we get through all those?
We actually have two more if you want to do them at some point.
Let's, you know what? We're getting close enough to the end. I think is it okay if we skip them?
Oh, yeah,
Of course.
absolutely.
Yeah, absolutely.
And Jeff, well, I want to make a comment, and it's not going to be poking fun at you, I promise, is when we're speaking about nomenclature, is that one of the things that popped into my mind when you were talking about the center involved is that we also don't want to be saying that we use evidence-based medicine. That's kind of become old and outdated. I spent a lot of time working with hospital-based systems and now these registries, and it's outcome-based is what we want. So, you know, it's the outcome of the result. So real quick example would be, you know, you have a chemical that can kill a cancer cell and you can show it in a petri dish and you're trying to get, you know, maybe some insurance company to cover it. But if the patient doesn't live any longer by killing the cancer cell, then what was the outcome? So, you know, we've moved, you know, so I hear a lot of people out there as optometrists when they're talking to the MDs of the medical community, like, oh yeah, we're evidence-based medicine. Just so people know that's becoming a little bit old. We do outcome-based medicine now, or that's at least what they're looking for.
Great point. No, that's great. That's what's important to patients. So I know we've only got, I'm supposed to be about another 6-7 minutes. And so we'll be done.
You know what, Jeff, we started a little bit late. So go to about, it's 8:50 our time. So you have about another 12-13 minutes. So.
Okay, perfect. So this is a tech comes to me in the middle of the morning and says, hey, Dr. Gerson, your friend wants to be worked in. I put friend in kind of quotes because when someone says they're your friend, that generally means they have your phone number, or they met you somewhere and they need a favor. And that was kind of the case with this. And as it turns out, this friend, I'll tell you about him. 46-year-old male who his complaint is some recent changes in his vision. I don't go to Starbucks, so I don't know what you're supposed to call the drink. So I just called what he had, a humongous Starbucks in one hand because it was a giant something, and then a bottle of water in the other. He's like kind of constantly going back and forth. He's always drinking something. And he says, yeah, over the last month or two, I've noticed not just my vision's changed, but I haven't been feeling very well. And I knew his medical history is that he had a pituitary adenoma, for which we had always done visual fields at the direction of his neurologist. And Jake's other big, excuse the pun, issue is he's about 5'11" and weighs 375 pounds. And you don't need to know the scale of BMI when I tell you that his BMI is 52 to know that he's way too big. Someone with a BMI of 52, essentially anyone that weighs 375 pounds is obese to some level. So what do you want to know? What do you want to do with this patient? And so he was complaining about his vision. So the first thing I wanted to do is kind of figure out what was going on with his vision. He actually corrected a 20/20 with a 1 diopter hyperopic shift. He had a normal eye exam, but he was worried about his pituitary, so he wanted me to do a visual field. And what I told him was, Jake, I really don't think that this is a pituitary issue, but if it'll make you feel better, we'll do a visual field. But before we do that, I want to check your blood sugar, because really what I'm worried about is diabetes. He said, yeah, that was kind of on my mind too, but can we make sure to do a visual field? Okay, sure. So I decided to do the blood sugar first and do a finger stick. And that's what the monitor said. It said high. And I thought, well, I haven't done this for a while, so maybe it's like waking up. It's like, hi, how you doing? And so let's do another one. So I did it again, and that's what it said. No, not really, but it was too high. So Jake goes to do his visual field. And while he's doing the visual field, I look up online when this particular model of monitor says high, or when it gives you this other reading, what does that mean? And what it meant was his blood sugar as he was sitting there. And I get it, he was drinking this big Starbucks drink, but his blood sugar was over 500. And that's pretty darn high. Doesn't matter what you're drinking right now, that's high. So while he's doing the visual field, I called his primary care doctor and said, hey, I got Jake here. Here's the story. What do you want me to do? And he says, hey, when you're done with them, why don't you send them over to the office and we'll double check, make sure of what the numbers really are and take care of them accordingly. Now, someone's asking if blood sugar testing is reimbursed in an optometry practice. I suppose it depends on your state or carriers. In my case, it is. However, a finger stick blood test reimburses like $2 for blood sugar. And to do it, it costs like 40 cents. I don't bill it. It's not worth the time and effort to try to collect a couple dollars for something that costs me almost nothing. So is it reimbursed? Yes. I don't bill for it. So when he's done with the visual field, he comes back. I say, hey, Jake, the visual field is completely normal. Good news. However, the blood sugar, this is what it meant. And as we briefly discussed earlier, my main concern is diabetes. I already called Jonathan, the primary care doctor. He wants you to head over to his office. Before you go, I would tell you, stop home, grab a few things, because if I had to bet, I'd bet that he's going to admit you to the hospital for a night or two to get things under control. Jake leaves the office. I go about the rest of my day, go home, and I get a phone call that night, and it's Jake. Because remember, he's my good friend because he has my phone number. And he said, you will never guess. He said, first of all, I went to Jonathan's office and yeah, my blood sugar was as high as you thought it was. It was over 500. He sent me to the hospital. He said, and you'll never guess what he said to one of the nurses in the hallway about you. And my first assumption was my friend Jake was calling to let me know how badly the doctor was talking about me in the hallway. That's kind of what it sounded like. But as it turns out, he said, you know what? He was talking to the nurse and he said to the nurse, you'll never guess how this guy got to us. his vision was kind of weird. He went to his eye doctor who checked his blood sugar and picked up on his blood sugar being too high and sent him to us. That's how he found out. I mean, that's like a first for me. That's pretty cool, isn't it? And that's what he said to the nurse. And so again, it was another one of those kind of feel good moments. Remember earlier, I told you my 2 best MD referral sources. Now this guy is my other really good referral source. So first what happened was Jonathan, the primary care doctor, came to me to see me as a patient. And 2 interesting things about his first encounter. Number 1 was he came in wearing contacts. I asked him to take his contacts out. He actually brought a case with him, which a lot of people don't. I almost wished he hadn't, because it was the ugliest, worst looking case I'd ever seen. I think there was a tree growing out of it. There was so much green on the case. It was disgusting. I immediately had him throw away the case and the contacts. The other interesting thing is Jonathan hadn't had an eye exam in a number of years. As it turns out, his first visit, his IOP was 24. When I looked in at his optic nerves, he was like a 0.6, 0.65. And when I had him come back to do a visual field, verified that he had glaucoma. And so Jonathan was impressed enough that now he then sent me his staff. So kind of one by one, people that worked for him came to me for the routine care. And now he sends his patients. So maybe I got lucky, but through taking care of people with diabetes and doing a really good job with them, it's really kind of converted Jonathan and then the endocrinologist to realizing that, hey, I don't need to send my patients with diabetes to a retina specialist. I don't even necessarily need to send them to an ophthalmologist. I can send them to an optometrist that knows and or cares. So I just thought that was kind of cool. So Jake's diet needs to be changed, but there's more to it than that. Can there be more to nutrition than just sugar and the right foods? And Greg kind of alluded to this earlier, and the answer is absolutely yes. That can you use a supplement to improve outcomes in diabetes, diabetic retinopathy? And you could substitute almost anything where it says diabetes and diabetic retinopathy. And the answer will be yes. Yes, you can. If you're using, and boy, Greg, we could talk for an hour or 2 about the importance of high quality supplements and using the right ones. So I'm going to talk about it for like a minute, but that could be an hour or 2 discussion. It's an important thing. And it's important to realize it's not just take a vitamin or take a multivitamin. There's so much more into it than that, that maybe that's a topic for another night. Was I concerned about Jake driving to his primary care doctor with his blood sugar that high? I was not, because this is not something new. It's not like he said, I've been doing great, and then all of a sudden I noticed something. He's been running high for a very long time. Just like when you find someone, you uncover blood pressure that's 220 over 130, it didn't happen overnight. And if you call the primary care, they're not going to be nearly as excited about it as you are. So no, so I wasn't concerned. One of the doctors is commenting they've been checking blood glucose for a long time, and they discover undiagnosed diabetes every year. And many times people that have diabetes that are uncontrolled. Yeah, it's a very informative test to do it. And if nothing else, it can save you a lot of glasses remakes. Because if someone, while they're sitting in your chair, their blood sugar is 400, but their A1C is 6.5 or 7, that tells you they're in an excursion. They're very high compared to normal, and you don't really want to base a refraction on that.
Hey, Jeff, there's a one that came in private while you're taking questions.
Yeah.
It was sent to me, and it says, what is a good blood sugar machine to have in the office?
So kind of like the diet question, my answer to that is yes. I think really almost any of them are a lot better than nothing. They all come with ways to calibrate them. So honestly, I would just tell you, go to the store and buy one. And one way to check which monitor is how much are the strips? What do the strips cost? You don't need one that has strips that cost $4, or that's an exaggeration. Sometimes strips are up to $1 each. Find one where strips are a quarter each, so that you don't feel like you're having to spend a bunch of money every time you do it. So I think any monitor is going to be better than no monitor. That would be my answer. So a paper that was published, really, I mentioned Paul Chaus earlier, that he really drove this, looking at using a specific supplement to try to affect eye findings. And Paul showed that with the right supplement, you can improve contrast, color, a 5-2 visual field, macular pigment, blood markers of LDL, HDL, triglycerides, high sensitivity C-reactive protein. What you don't affect is A1C, which is good, because if someone has good control, is there something else we can do to try to help them in their eyes? And the answer is yes. So there are different things that we can do to create improvements. By the way, one of the things the last thing on here that was really significant was diabetic peripheral neuropathy sensitivity score. So there's things we can do to help our patients with their diabetic peripheral neuropathy. And probably about the only thing that will make someone as happy as saving their vision or helping their vision is if you can do something about their peripheral neuropathy. And the driver of that in this supplement was something called benfotiamine, benfotiamine. I actually have a good friend that I just recommended it for, who has some post-chemotherapy neuropathy, although it's shown to be most effective in diabetes-related neuropathy. So there's things we can do beyond just eat the right foods and exercise, being on supplements. Now, by the way, there's a number of things that I did not talk about tonight, and it's because I knew I wouldn't have enough time, but I wanted to give each of them a quick mention, because each of these could be a whole talk, maybe not a whole talk, but 10 minutes of their own. The value of intermittent fasting. And intermittent fasting means different things to different people, whether it's, eat one day, not the next, or only eat during certain hours each day. But intermittent fasting can be very effective in helping to control diabetes or reverse to where someone no longer has diabetes. Something called photobiomodulation, which is basically using a specific wavelength of red light to stimulate retinal cells and improve diabetic retinopathy. Also shown to be beneficial in AMD. This is something that's in phase 3 clinical trial in the US, already being used in Europe. And by the way, in Europe, it's being used by optometrists. And rules for optometry in Europe are far more prohibitive than they are in the US. So I'm very hopeful that A, this will work, but B, it'll be something we can provide for our patients. Lastly, there are a number of new systemic and ocular medications that are out there. So, diabetes is something that's ever changing. And to know all the medications today is great, but we need to, refamiliarize ourselves and learn tomorrow what the medications are. In the eye world, by the way, so the ranibizumab, NUNA, so the biosimilar that's the most recently approved. I think what may be next to be approved as far as eye for intravitreal injections is something called faricimab, that with it, about half of people are able to go 16 weeks in between injections. So dramatically decreasing burden on patients. So my quick summary is that, and I started with the conclusion, so I guess I don't really need to conclude, but I guess my summary is that, again, most people with diabetes don't get good control. It's something we can help talk to them about, and the earlier they do it, the better. Glucose control is still important for prevention of diabetic retinopathy, even if it's not A1C and it's time and range. Good control is important. Anti-VEGF therapy is important, not just once you develop macular edema, but before someone even gets there, to reverse retinopathy. And that better diet and targeted nutritional interventions and talking about other lifestyle things like exercise are so, so important, and something that we can do. The question, what was the drug you mentioned for neuropathy? So the supplement in Paul's trial was called DVS from iPromise. The thing in it that we think is probably what drove the improvement for neuropathy is called benfotiamine, BENFOTIAMINE. And it is very readily available. All right, so Greg, you said to finish at 50 after. I think we're at 52, so I guess I went a minute or two over, but happy to entertain any questions before I put that out there. Joe and Greg, I want to thank you for having me. and just how impressed I am to have a virtual live education on a Sunday night and have nearly 170 people on is really fantastic. So thank you for having me. And again, open to any questions anybody has.
Well, thank you, Jeff. I mean, I don't think you went over. I think your timing was actually impeccable. Probably right down to the minute.
Thank you.
There was a fantastic, easy to digest, broad, expansive, well-researched talk, not just on the aspects of diabetic retinopathy, but really a great extent knowledge of diabetes in general. So we really appreciate that. I think everybody in the audience, I'm sure, appreciated that.
Sure. Thank you.
Hey, Jeff, I'm not sure if you have access to a keyboard, but if you can, maybe just chat that or type that into the chat box there. Maybe that will help the audience out.
To put what in?
The nutraceutical that took care of the neuropathy.
Yeah.
If you want to type that in, that might be helpful. Joe, I want to thank, or Jeffrey, I want to thank you for doing this. Joe said it so nicely, so I'm just going to basically just say, I just echo what Joe said. Great job. Thank you for doing this. That will end the CE part of Modern Day Diabetes by Dr. Jeffrey Gerson.